Good afternoon, everyone. I'm Goli Sheikh-Islami, President and CEO of New York Public Radio, and I want to start by thanking all of you for joining us today. A special thanks to Sikan Akban, WNYC's new Health and Science Editor, Christopher Worth, Science Editor of WNYC's Narrative Unit, Senior Editor of WNYC's Narrative Unit. I have science on the brain. Also, the incredible roster of panelists who've taken time out of their very busy schedules to take part in today's conversation. And of course, Doran Weber, the Vice President of Programs at the Alfred P. Sloan Foundation. The foundation's support has been fundamental in allowing New York Public Radio to build the pioneering WNYC Health Unit, and it has been the impetus for this annual convening, which has been a highlight for our teams 7 years running. On behalf of all of WNYC, I am extremely grateful for the Foundation's continued partnership. I am as eager to hear from today's panelists as you are, so I will keep things brief up top and share just a few thoughts with you this morning. And I'll start by stating the obvious. There has never been a greater need for accurate, nuanced, and accessible health and science reporting than there is right now. More than any time in our history, science has become a part and an urgent part of the lives of everyday Americans. Over the last year, we have become armchair virologists. We've become obsessed with material science as we compare the efficacy of mask fabrics and debate their continued necessity. And we've come to understand with painful clarity how policy around public health has real and intimate impacts on our private lives and the health of communities where we live. And at the same time, we're asking questions about the repercussions of the pandemic on the climate crisis and asking how we as a society can prioritize the conflicting demands of an ever-changing planet. Thanks in large part to the support of the Sloan Foundation, WNYC was already a leader in health journalism, and our strong foundation let us work collaboratively to weave a health focus into every one of our beats as the pandemic hit. As we continue to deepen our coverage, we will focus on community health and the environment, concerns which will only become more important in the coming months and years. And as always, we will focus on the disparate ways that our systems impact the many different populations that make up our city. I'm grateful to have brilliant colleagues leading this work and to have such a strong community of partners and experts like those with us today to help in the broad project of making health and science accessible to everyone. So thank you once again for joining us. And now I'll pass things over to Doran to share a few words as well.
Thank you, Goli. Hi, everybody. It's a pleasure to be here. I wanted just a few words about the Sloan Foundation. For those of you who don't know us, we were founded in 1934. We're New York based, and we make grants for research and education in science, technology, and economics. One of our signature programs is Sloan Research Fellowships. And I'd like to say we're good at picking winners. 50, they're given to scientists early in their careers, and 50 of them have gone on to win the Nobel Prize, including this year, Andrea Ghez, who became the first female astronomer and only the 4th woman in physics to win. The first, as many of you may know, was Marie Curie. Our program in public understanding of science technology, under which this grant falls, is basically focuses on commissioning, developing, producing, and disseminating an array of culture-defining products, books, radio, television, film, theater, and new media, all aiming to bridge the two cultures of science and the humanities and to translate science for the lay public. So you can think of us as a kind of nonprofit multimedia company for science. We were founding sponsors of Radiolab, Tribeca Film Festival, World Science Festival. We made a book grant to a then unknown author named Margot Lee Shetterly for a book that became Hidden Figures and then became a hit film, as many of you know, and a kind of cultural milestone. We're longtime supporters of American Experience and Nova on PBS, plays like Proof, Copenhagen, Behind the Sheet, and a recent film Picture Scientist about sexual harassment of women in science. During COVID, like many other funders, we've been focused on trying to educate the public about what was going on. We had a 4-part series called Extra Life with Steve Johnson, David Osoga on PBS recently. We have upcoming American Master Show on Anthony Fauci, which will focus on the arc of his entire career. So as you know, recently he was vilified by the right, but in the 80s he was vilified by the left during the AIDS pandemic. So we're going to look at his entire career. We're supporting David France documentary about the research and development and distribution of vaccines. And we've had several pieces on the NewsHour about the crisis in Brazil, their response to COVID, and even drive-in films at the Museum of the Moving Image about public health. And we're supporting a new book about bats and their role in disease. So finally, I'll just say that when Laura Walker came to me with this idea for a health unit, I think it was about 2014, I immediately said that's a great idea because health touches every aspect of our lives. And of course, science, to truly understand science, health, you need to engage with science. And of course, you need science to improve health, as we all know from what's happened during the pandemic. And while none of us foresaw COVID specifically, I will say that while Bill Gates, God bless, is given credit for being prescient in 2015 with a TED Talk, it was a 1992 report by Josh Lederberg, a National Academy of Science report, Emerging Infections, Microbial Threats to Health in the United States, that alerted the scientific community, I guess that's almost 30 years ago, that this was likely to happen. And as we all know, it's probably going to happen again. So we're really grateful to WNYC for doing such an incredible job. We're very happy to have all these wonderful speakers today. And my final note would be that while science, of course, is absolutely critical and essential, and we would not have gotten this far, we need to also retain some humility and remember that science by itself, it's absolutely necessary and critical, but it's not sufficient because all of these things unfold in a larger social, socioeconomic, and cultural context. So with that, thank you very much, and I look forward to a great panel.
Hello, I'm gonna adjust my camera real quick, just a little bit. Hi, I'm Sikon Akban. I'm the Health and Science Editor for New York Public Radio Gothamist, and I am very excited to be hosting this session today, along with Christopher Worth. I want to thank you, Goldie and Doran, for the introduction. Also, many thanks to the Sloan Foundation for supporting this program. Just a little housekeeping at the top. We've collected some questions in advance, but we also want you to send in your questions using the chat function. And with no further ado, I think we are ready for our first panel. So our first panel today is going to be about the future of mRNA vaccines. And we have Dr. Jeffrey E. Harris and Dr. Celine Gounder to speak with us. Dr. Harris is a professor of economics. Dr. Harris is a professor of economics emeritus at the Massachusetts Institute of Technology and a practicing physician at Eisner Health, a federally qualified community health center in Los Angeles. Dr. Harris recently published a working paper issued by the National Bureau of Economic Research entitled "The Repeated Setbacks of HIV Vaccine Development Laid the Groundwork for SARS-CoV-2 Vaccines," which we will get into. Dr. Celine Gounder is the CEO, president, founder of Just Human Productions, a nonprofit multimedia organization. She's also the host and producer of American Diagnosis, a podcast on health and social justice, and Epidemic, a podcast about the COVID-19 pandemic, for which we are discussing. She previously served on the Biden-Harris Transition COVID-19 Advisory Board. Dr. Gounder is a clinical assistant professor of medicine and infectious diseases at New York University's Grossman School of Medicine. She cares for patients on the wards at Bellevue Hospital Center as well. So I want to start by thanking you both for joining us, and also feel free to tag on to each other's answers, even if I don't pose a question directly to you. So I want to start this panel discussing the short-term future of mRNA vaccines, and then chat about the long-term prospects. So I think the two biggest issues in the short term with mRNA vaccines, or really any COVID-19 vaccines right now, appear to be access and hesitancy. So, Celine, on the latter point of hesitancy, WNYC Gotham has published a story just this morning about how the largest healthcare union in the United States, which is based in New York, is vowing to fight mandatory COVID vaccinations. You know, while uptake among healthcare professionals has been strong, you know, there have been pockets of resistance, which I think mirrors the situation in the general public. You know, what are you hearing from healthcare workers in terms of their reluctance, and what would you recommend to address this hesitancy, and how might those ideas be applied to the general public?
Yeah, thanks for that question. And it's great to be here with all of you today. So as somebody who works for health and hospitals here in New York City at Bellevue, I have been working with the team at H&H to help educate our own healthcare workers. We've been doing webinars, providing folks with information about the vaccines and really trying to, in a sense, train amplifiers of the message. So give them the tools that they need to then educate their patients, educate their coworkers, their families, their communities. I do think it's important to understand that healthcare workers are just like anybody else. And so many of the same reasons why other people have barriers, especially in terms of confidence in the vaccines, really apply to healthcare workers as well. I will say healthcare workers, there have been some reports of issues with barriers. I think that really tends to apply to people who work, for example, in long-term care facilities. You have some of these workers who may be juggling multiple jobs at different long-term care facilities where it's harder to access perhaps on-the-job vaccinations. At a place like Bellevue, you walk in the lobby and it's right there. So for most healthcare workers, at least at the big hospitals, it really is not an access issue. It's really more of a confidence issue. What we're also seeing is that if you break it down by profession, by race, by socioeconomic status, you really see trends where doctors who are at the high end or at the top of the totem pole are very confident in vaccines, where you have nurses or perhaps ancillary support staff being less confident in the vaccines. And I think this is a reflection of being confident in your employer, feeling like you have agency in the workplace, that you have control over your workplace, the rules of the game, so to speak, and that you're not just at the whims of what you're being told to do. We are also seeing hesitancy or lack of confidence in vaccines by race, unfortunately, and that might seem counterintuitive. You might say, well, you know, you're a woman of color who's been working throughout the pandemic. You have seen what this has done to people just like you. And at the same time, I would also argue that if you work in healthcare, you are very aware of the racism in healthcare. I cannot tell you how many times I have had a Black or brown patient tell me when I'm rounding on them in the morning at the hospital that they are sick and tired of the racist attitude of the staff, and they're tired of being treated, and I will quote directly what patients have said to me, like animals. And where I hear this actually most strongly spoken is by patients who are not born in the United States, but who are Black and brown, who know to expect better care, more respect in other settings, and then, you know, encounter care in the American medical system and feel really discriminated against. And so when you work in a setting like that and you bear witness to that every day, how can you expect healthcare workers who are Black and brown themselves to trust that the healthcare system is really looking out for them? So I do think we have some very real challenges in the culture of medicine that many of us don't want to acknowledge that these are problems. And then finally, with respect to this question of mandates, you know, the fact is we do actually mandate other vaccinations as part of work requirements. So in New York State, for example, all of us working in healthcare are required to get an influenza vaccination every year, or we have the option of wearing a mask. And so I think if you construct these mandates where you at least offer people reasonable alternatives, and that reasonable alternative in the case of COVID might be testing them, mandated testing as an alternative to vaccination, maybe once or twice a week. If they're offered the option, I think it's quite reasonable to mandate vaccination in that setting. The fact is, patients need to have some control over their health and safety as well. If you are somebody who has had an organ transplant, who has some other high-risk condition, you know, I think you have the right to also expect that your care will be safe and that you will not acquire another infection as you seek healthcare. So I do think there are different priorities that do need to be balanced there.
Perfect. And then Jeffrey, to tag on to that, you've written about how community health centers and telemedicine can help stamp out the pandemic. And, I think a lot of that writing sort of centers on some of the issues that Celine just raised. I was wondering, could you briefly describe, what these health centers, what telemedicine can provide to an urban center like Los Angeles or like New York City to address issues of hesitancy and access?
Well, thank you very much for having me. I work at a community health center in the heart of Los Angeles. Our health center is exactly located where the people need the access. We're not a big health center. Well, we're a medium-sized health center, but we've already vaccinated about 12,000 people. And our data suggests that more than half of them do not have any health insurance. I'm talking about not just no private health insurance, no Medicare. I'm talking about no health insurance at all. My own analyses suggest that more than half of them have no more than a grade school education. Community health centers are a way to get to those people who are the least accessible. And they also provide a source of what you would call trusted advisors in the form of physicians, nurse practitioners, and others who can answer their questions one-on-one about really what fears or concerns they have or things they heard or read in social media. Tagging on to what Dr. Gounder said about vaccine mandates, let me take off my medical hat and put on my economics hat for a second. From my standpoint as an economist, vaccine mandates are inevitable and unstoppable. And they're going to come, first of all, leading the way are not only healthcare institutions like Houston Methodist, which mandated vaccines and got 97% of employees to cooperate and vaccinate themselves, but also healthcare institutions, where the Chronicle of Higher Education has now counted more than 500 colleges and universities that will mandate either vaccines for students or for faculty or staff, or both. The incentive is going to come from management, because management does not want the disaster of an outbreak, which could shut down either a school, a hospital, or a business. And the employees, as Dr. Gounder said, people have different motives. It's true that practicing physicians have the highest rate of vaccination. The AMA came out a couple of days ago with an estimate that 96% of practicing doctors are already vaccinated. But the impetus to get these things going is going to come from management.
And to stick on the topic of access, Celine, in our pre-interview, we chatted about a program that centers around barbershops and hair salons. And you also mentioned a tactic that your little sister's school took. I was wondering if you could talk about both briefly.
Yeah, sure. And I also just want to note that, Jeffrey, who works at a community health center, federally qualified health centers are an important part of the Biden strategy for getting vaccines out to communities of color in particular. Well over half of the vaccines that are delivered through the federal avenues, some of that includes these community health sites, are being delivered to Black and Brown communities. So that's a really important part of the strategy. But as you mentioned, this Shots in Shops program, which is literally getting your vaccination in the barbershop, Shots in Shops, was pioneered by the University of Maryland. And has been really effective. When you think about it, if you're somebody who cares about your health, your wellness, your appearance, the barbershop, the beauty salon is where a lot of people, frankly, get their information, kind of like you might get your health information from your, personal trainer or somebody at the gym. And so these have been, studies have actually shown even prior to the pandemic that these are really important avenues for providing information about health There's a paper in the New England Journal of Medicine, as well as in JAMA a couple years back, looking at hypertension control through outreach at barbershops. And that was highly effective in a way that doing the same thing in a primary care physician's office may not be as effective. These are simply places that are more accessible and where people just feel more comfortable speaking to somebody who they've known for a long time, who they trust, and trust that kind of information from. So this is now being expanded across the country with support from the US government. And we're really hopeful that that will bridge some of these gaps with respect to communication, especially among younger Black and Brown Americans, where we do see lower vaccination coverage rates. You mentioned my little sister. So my little sister is a high school principal in Houston. Most of her students are also Black and Brown, many Latinx families, and many of them are Spanish speaking only, at least the parents. Some of them are undocumented, and that creates its own barriers. She has found herself having to help some of the parents just sign up for an appointment online because they couldn't navigate from a language perspective, from an internet access perspective, maybe only having a basic phone. Or even if it was a smartphone, the idea of having to navigate the vaccination appointment websites on that, it can be very challenging. And so one of the things she did eventually was, once the Pfizer vaccine was authorized for use in 12 and up, arranged for vaccination to occur at the school and opened it up to parents too. Because what she found was that, one, she was able to get information to families through the students, send information home to those families, and then invite everybody to the school, the kids and families included, who had not been vaccinated yet, to get vaccinated on site. And when you think about it, if you're a working parent, the school is a place you may already go to. You might be dropping off your kid or picking up your kid. So it's not steering somebody well out of the way of their normal routine. It's really quite an accessible point of accessing vaccines.
Perfect. And another aspect of access is logistics. And we received a question ahead of the convening that Jeffrey, I think, speaks to some of the things that we had discussed earlier. How will we learn to develop mRNA vaccines more quickly tailored and also, how will we learn to develop mRNA vaccines that are more quickly tailored to less impactful diseases, and also the mutations that we're seeing with the SARS-CoV-2 virus? And I was wondering if you could tackle that and also speak to some of the what that might mean around the economics of the vaccine and rolling it out to people in the future.
Well, thank you for that question. That's a hard question. I hesitate to say so, but it depends on a lot of things. It depends first on what I would call execution versus concept. We already have the concept, mRNA vaccines. The execution is another matter. It's the difference between seeing a recipe and saying, oh, I'll prepare this fancy dessert, and actually knowing how to do it. And a lot of that know-how is in the form of current trade secrets and patent protection. From the economic standpoint, to the extent that that patent protection is maintained, that may make it difficult for other firms in the industry to apply mRNA vaccines to different other diseases, not only infectious diseases, but even cancer. That's one factor. On the other hand, economists know that intellectual property isn't a perfect barrier, and knowledge about vaccines and know-how gets leaked. And it gets leaked more than often in the case of vaccines when there is a phase 3 clinical trial, such as the CureVac trial, which was publicized very recently, in which it did not live up to expectations. In other words, failure in some sense is a greater stimulus to diffusion of knowledge than success. And now we're going to have to figure out why CureVac didn't work. It only had a 40-something% efficacy. It wasn't statistically significant. We don't know what its efficacy is for severe disease. That wasn't put in the press release. But we don't know whether or not it had to do with know-how. It had to do with the preparation of the mRNA, which is proprietary. Was it stable enough? Did it actually stimulate immunity? And then there's the issue of the variants. Of the 124 cases where they actually did the genome analysis, 123 were variants, and the most prominent variant was something called Lambda, which is it's in Peru and Colombia and South America, but it is so far poorly characterized, so we don't know that much about it. On the whole, though, it's really going to be a question of economic investment. How much money are we going to put into it? If you look at the investment in HIV vaccines, you're talking about $15 billion or so over the last 19 or 20 years. When it comes to COVID, the latest estimate I've seen is about threefold that, just for about the first 6 or 7 months of 2020, I mean. How much money we put into it and how fast we move is going to be important. And I think a lot of things were in our favor. In some sense, we were scientifically lucky to have the mRNA vaccines come out or be ready just to get out of the starting gate, just as this epidemic came. And I'm hoping that not only the scientific community, but policymakers learn from that lesson.
And then, you just brought up the variants in the vaccine, which I think is a topic on people's minds right now, given the Delta variant. And I might open up this question to the both of you. And this is a question that we also received ahead of the event. And I would remind people who are watching that you can submit questions in the chat, and we will get to them eventually, hopefully. We've been hearing that the mRNA vaccines are effective in combating the COVID Delta variant. But where does that leave people who got single shots like the AstraZeneca and Johnson & Johnson? And I'm going to tag on to this question to say that the data that we've seen so far out of the UK, looking at vaccine effectiveness against the Delta variant, has focused on Pfizer and AstraZeneca. And while AstraZeneca is a single shot, it is on a similar platform as Johnson & Johnson. They actually have a slightly different molecular approach. So we need to sort of wait to see what's going on with Johnson & Johnson. So I'll leave the rest of the question to you. What does it mean going forward for people who have taken a single shot vaccine, the Delta variant?
Right. Well, I would correct one thing. AstraZeneca is a 2-shot vaccine. Johnson & Johnson is a 1-shot vaccine. And one of the key differences between the AstraZeneca vaccine versus Pfizer, Moderna, and for that matter, J&J, those three incorporate a technology that stabilizes the spike protein that's produced in the body. So with mRNA, it gets translated into spike protein. And there's something similar that happens with adenoviruses. You have a couple more steps in that process, but you end up with spike protein that's synthesized by cells. And the way that is done using the Pfizer, Moderna, and Johnson & Johnson vaccines, that spike protein is stabilized in a particular conformation, whereas the spike protein that you get from the AstraZeneca vaccine, you could say it's flip-flops between different conformations. And so it's not as stable, and the immune system therefore doesn't have as stable of something to recognize. So that is an important distinction between those vaccines. Now, should you get, let's say you got the Johnson & Johnson 1-shot, I have been getting a lot of questions about this. And what I would say is, for the average person, I would still recommend, let's wait and see, get some more data. However, if you are somebody who is at very high risk for severe disease, somebody who has who's older, who has certain underlying medical conditions, if you are somebody who may not have responded as well to the vaccine because you have underlying immunosuppression, we have seen, for example, organ transplant patients who are on a lot of immunosuppressive drugs do not respond as robustly to the vaccines as do other people. So if you fall into one of those categories, and you are in a part of the country where there's already a fair amount of the Delta variant, so places like, the New York City or the New York tri-state area, where Jeffrey is on the West Coast in California, those are places where we're seeing a lot more Delta variant. In places like Seattle, we're actually not seeing a lot of Delta variant yet. So I would say, depending on the local epidemiology, depending on your own risk for COVID, if there is increased risk of being exposed to Delta, if you are at increased risk for not responding to the vaccine or have increased risk of severe disease, in those people, I would recommend getting an mRNA vaccine, a second dose after your Johnson & Johnson, but that second dose should be either Moderna or Pfizer. We don't yet have data on 2 doses of Johnson & Johnson. And what we've seen, there is some preliminary data on giving a dose of mRNA vaccine after Johnson & Johnson or after AstraZeneca. There do seem to be a higher rate of side effects, but those are pretty much your run-of-the-mill side effects, the fever, chills, fatigue that we see with vaccines in general. And you may have heard Angela Merkel recently had a similar mix and match experience. I think it was AstraZeneca for the first, and I believe Pfizer for her second dose. So that would be my recommendation for that very specific situation.
Yeah, and thanks for, excuse me, I misspoke. The AstraZeneca vaccine is 2 shots, but they were delaying it by up to, I guess, 12 weeks in the UK. So my bad. Jeffrey, what are your thoughts on that question? How do we go forward with the Johnson & Johnson vaccine and given the Delta variant?
Well, let me tag on to some of the comments of Dr. Gounder. Again, putting on my economist hat. When we talk about stabilizing, excuse me, the fact that some of the vaccines are different because they stabilize what is called the spike protein, which is the key protein which unlocks the door so that the coronavirus can enter the cell. That stabilization is governed by a patent, which is currently owned by the United States government. And the strategic decisions that the United States government and perhaps the US Trade Representative make in the coming months concerning the licensing and applicability of that patent may make a big difference as to the availability of some of these vaccines in countries other than the United States and Western Europe. With respect to the variants, let me tag on back to the idea about vaccine mandates. The variants pose a serious question, and I think health officials in the CDC, Dr. Fauci, many others have said, look, this is a major source of uncertainty, and I think Dr. Gounder has emphasized that as well. They raise the question for a manager of a healthcare institution, an educational institution, or in any other sector, there's the risk of an outbreak, which is significant. And I think that's the stimulus whereby managers of organizations other than healthcare and education, Morgan Stanley in the financial sector has mandated vaccines for its employees. Delta Airlines has mandated vaccines for all new hires. I think that based on the economics, if you're going to talk about the most significant incentive for those people who have been hesitant so far, as much as I'd like to say it's the advice of us practitioners down on the factory floor in the battle who are answering questions about people who have their own fears and concerns, we do our best we can. But in the end, it may be, if you want to go back to your job, you're going to have to get vaccinated.
And then, before we really get into the heavy part of the Q&A, Jeffrey, I wanted to touch on your NBER paper about how failures with developing vaccines for HIV, sort of paved the way for the SARS-CoV-2 vaccines. You want to just talk a little bit about what was in that paper?
Well, we've been trying to make an HIV vaccine for more than 3 decades, and we haven't been able to do it. And from the strict standpoint of producing a vaccine, it's been a failure. But it actually hasn't been a failure at all, because the knowledge we've learned directly in the study of viruses, directly in the study of immunity, has been applicable to the development of vaccines throughout that time period. And it's not simply general knowledge. The major technologies which are in use now, the purified protein, the viral vector, even mRNA, were all developed during the attempt to get an HIV vaccine. Today, 6 out of every 7 vaccine candidates, which are either approved or in clinical trials throughout the world, take advantage of one of those new technologies that was developed during the attempt to have an HIV vaccine. There's a good case to make that we may still be able to develop an HIV vaccine in the future. It's really a question, do we need a new concept or is it just more execution? Do we already have the recipe and we just have to keep doing it over and over until we get exactly the right combination of ingredients and cook it in the oven at the right temperature for the right time? Or do we really need a new concept entirely? I'm in favor, actually, of the fact that I think if we just try harder, we'll get there.
And then, Moderna, some academic labs, they've discussed using mRNA vaccines to tackle HIV, to tackle cancer, to tackle pandemic influenza and also seasonal influenza. In terms of not only access to those vaccines going forward in the United States and globally, are these pie in the sky ideas, or do you think they're obtainable? And if we can make those vaccines, does global access to them just come down to making them, or what else might be needed?
If you're asking me, global access is going to depend critically on policies of different countries to intellectual property rights. And it's going to be who gets the license and sub-license a patent. We'll see what happens in the near future, especially since in May, the US Trade Representative came out in favor of relaxing some of those standards so that other countries could take advantage of the intellectual know-how, which has already been developed and still patented. We'll see what happens. In the meantime, phase 3 clinical trials, as I've said before, seem to be the vehicle by which know-how gets leaked. When Merck, a pharmaceutical company, set up a trial of a viral vector vaccine for the first time for HIV, this is now more than 15 years ago, this is the same technology which is being used in AstraZeneca, Johnson & Johnson, and many others. The vaccine trial did not work. It seemed to stimulate what was called cellular immunity, an important part of human defenses against viruses, but it just didn't reduce HIV cases. But the search to try to find out why it didn't work led to a whole explosion in technology. The same thing may happen with the CureVac trial. It didn't work, and trying to find out why it didn't work may end up expanding the field and leading to new developments which will really enhance the access and the applicability of mRNA vaccines.
Perfect. Yeah, and Celine, same question with a slight spin on it. You've worked on Ebola. What do we really need in terms of on the ground resources to get mRNA vaccines to doctors' offices around the world?
Yeah, sure. And I also just want to go back to something Jeffrey was saying earlier about how a lot of the research on HIV vaccines have actually paved the way for a COVID vaccine. A lot of, during this pandemic, people who worked in HIV, other infectious diseases, pivoted to COVID research, in the midst of this emergency. And many of them are now finding themselves in hot water because that research funding from the NIH was meant to be spent on HIV. And so we really need, it's crazy that they're having to now justify the work that they were doing, but we really need to make that funding far more flexible, where researchers are not working in silos the way they have been. As somebody myself who has worked in HIV and tuberculosis for many years, since the 90s, those are often infections you see, what we call co-infections, where somebody who has HIV is at increased risk for developing active TB. So you often, especially globally, see them to go together. And the idea that you would not have flexible funding that would allow you to work on, both of these in tandem is really a problem. And similarly, when you have an emergency like this, people who work in related fields, relevant fields, should have the ability, the flexibility to reallocate their resources accordingly. Now, with respect to global vaccine equity and the mRNA vaccines, I agree with Jeffrey, intellectual property is one part of the problem. So it's this 070 patent owned by the US government, which is for the spike protein stabilization, that is really a lever that we can use here. However, that is sort of like saying, on the West Coast, you have Thomas Keller's French Laundry, and here in New York, you have his restaurant Per Se, that you now have the right to make some famous dish of his does not mean you have the skills of a Thomas Keller to actually execute and make it. And so intellectual property is only one small piece of the puzzle. The actual manufacturing know-how may in fact be the more important part of all of this. So you need to know how to manufacture. Some of that includes, the staffing, the equipment to do that. You need to have some of the samples of the products along the way as you are making the vaccine, what those different components are. And then you need to have access to raw materials. So one of the major raw materials that also has its own intellectual property issues is the lipid nanoparticles that are used to make mRNA vaccines. So you need to have all of those things in place. There's also been a lot of reluctance on the part of the big pharmaceutical companies to partner with contract manufacturing organizations around the world. So this is, how, sort of notoriously, I suppose, Emergent Biosolutions in Baltimore, Maryland was manufacturing both the Johnson & Johnson and AstraZeneca vaccines, ended up with some issues of contamination at their site and had to shut down. But that's a contract manufacturing organization. And so there's been reluctance to really share with all of the capacity around the world. You have places in Bangladesh and in India and South Africa, in other regions that those companies have not wanted to share their technology with. And I will be quite frank, I think part of the fear is that the intellectual property may not be respected. I think there's tremendous fear by the pharmaceutical companies as well as the US government that countries like China and Russia will not respect intellectual property rights after the pandemic. And so if we share that manufacturing know-how, that the cat's out of the bag at that point. And these are highly lucrative products, these mRNA vaccines. It's not just about creating vaccines for infectious diseases. It's also about creating vaccines for cancer. So you may have heard about immunotherapy, where you train the body's immune system to fight cancer. This is precisely what could be done with mRNA vaccines. And that's a far more lucrative market than the COVID vaccine market. And that's precisely why they're so protective of those intellectual property rights. And so, Sakan, when we spoke the other day, you asked me, do I think that this could actually address access and reduce disparities? I think it may do the opposite, because there is so much profit to be made off of these mRNA vaccines that we're going to be seeing companies, the US government, less likely to want to share that technology, where what we really need is regional self-sufficiency with vaccine production. I think the case of the Serum Institute in India is a very good example of why relying on one company to produce vaccines really for the world was a mistake. I mean, not to disparage the Serum Institute, but India found itself in the middle of its own COVID surge. There have been restrictions placed on export of vaccines produced in India out of the country, and they're not able to get the raw materials into the country, in part because we have used the Defense Production Act here in the United States to block export of those materials. And so you really need to have regional self-sufficiency around the entire supply chain in terms of manufacturing to make sure that certain regions are not left out in the cold in a situation like this.
Perfect. And then we have a couple of minutes left, and I want to get to one question that was submitted. We're talking about regional access to the vaccines currently, but we know that certain areas have fallen behind, and we're starting to see surges in those places. We're also starting to see some surges in places, or I should say some upticks in cases in places that have solid vaccination rates, but they're around, maybe like 60%. If this pandemic starts surging again, I think there are going to be a lot of questions from the public. What can journalists do? What can I do? What can my colleagues do to improve our coverage going forward? What would you like to see from journalists in terms of stories, in terms of how they cover the pandemic in the future? And I guess we can say, namely around vaccines, but maybe just in general. To both of you.
Yeah, I mean, I can jump in to start. So I also just spent the last 18 months as a CNN medical analyst. I'm often a source for people like you guys at NPR, elsewhere, the New York Times, et cetera. So I've had a lot of interaction with the media over the course of the pandemic. I think there are a couple different ways in which the media covers these issues. One is what I would call a political lens, where are you for or against something? Are you for or against masks? Are you for or against airborne transmission? Are you for or against lockdowns? Are you for or against reopening schools? And I could go on and on. Do you believe in the lab leak hypothesis? And very often, I would say that's the most common framing I see in the lay media about these issues. It's basically, are you a Republican or a Democrat very often, is the framing. And the problem with that is that's not a scientific lens. And that's what you do when you actually don't know the science well enough. You just resort to, well, there's two sides to every story. I'll just get some experts on this side and some experts on that side, and then I have a balanced story. I would say that's probably 90% of the news reporting you see. Secondly, you have what I would call a lawyerly approach to reporting, where people start with their conclusion. So this is what I think is the case, and I'm going to cherry pick experts who will support this. I would say, that's another maybe 5% of the news reporting out there. That is what I would consider opinion, not news. And unfortunately, that has masqueraded as news during much of the pandemic. And then you have what I would call true science reporting, where you start, scientific process is not, I start with a conclusion. You start with a hypothesis and you test your hypothesis. And that scientific approach has really not pervaded news reporting on science yet. And I would really love to see that happen, where you start with a hypothesis, should we reopen schools? Or, yeah, I think it would probably be safe to reopen schools in these settings. And then you go to experts from a range of relevant areas of expertise. So you don't go to a surgeon to get advice on industrial hygiene and ventilation, which has also been, the kind of problem that we've seen during much of the pandemic. And so I would really hope that the lens that people use in doing the reporting is the right one. And that also means that you need more scientists who are actually doing the news reporting. And I think a couple of publications in particular, The Atlantic, the New York Times, have hired some really stellar people who have science backgrounds, who actually know how to vet the science, who know how to read the methods section, which, by the way, if you didn't know, always read the methods section first when you read a science paper, and assess whether this is even worth reading beyond that. So I think that would be one important lesson I would say here. I think the other one is, I think much of the message that's coming out now in the news is, oh, the pandemic's over, we can move on with our lives. And that is just not true. The pandemic will not be over for years yet. And I think if you look at communities, even in this country, where vaccination rates are lower, rates of transmission are as high as they were at the peak in January. So this is not over even in this country. Those of us who have been vaccinated, which includes me, are very privileged. We are in the privileged 1% of the world where we can enjoy that. And that's something to enjoy and celebrate. But don't go around saying the pandemic is over. It is not going to be over in much of the world. And I cannot tell you, just on a personal level, hearing that from a reporter, when I have family back in India, I had just lost a third relative and had 2 other family members in the hospital with COVID, as I was being told by a reporter, oh yeah, COVID's over. That is just beyond offensive, and it's just not the reality.
Wow. And yeah, Jeffrey, anything you want to tag on?
Well, I think from the standpoint of a practitioner who talks to patients almost all the time and asks them what they think about vaccines, it's critical that the media dispel myths, which are coming out at like wildfire all the time, and try to address them scientifically and with data. One that comes to mind is the current myth that the COVID vaccine is somehow going to impair fertility, which is traced to a claim by one scientist that the antibodies originating in the vaccine will attack a key protein that's important in the placenta in the development of the baby. If this were, first of all, that's just not true. I think, and the media has to endorse this, has to explain this. But also, if it were true, it would mean that anybody who got COVID naturally and therefore had antibodies naturally against the virus would also have antibodies against this key protein in the placenta. That would mean that if it were true, which it isn't, it would mean that getting COVID naturally would have an effect on fertility, which there's just no data whatsoever to support that. And I think the media has well, I wouldn't say an obligation, but has an open opportunity to dispel some of these myths, which make absolutely no sense. I think in the broader sense, the media has to be careful in the way it covers some of the developments that are somewhat outside the science, but are still within the realm of COVID. I was disappointed to see the recent coverage of a federal court decision in the state of Florida saying that the CDC's recommendations concerning vaccinations in cruise ships were an overreach on the part of the agency, the CDC, because things had changed, almost as if saying, as Dr. Gounder just echoed, oh, the vaccine, the epidemic is over, we don't really need these restrictions. The fact is, the cruise ship industry was not a party to that lawsuit. And the cruise ship industry, from the economic standpoint, having been battered through the epidemic and closed, has an enormous economic incentive to make sure that the crew and the passengers are vaccinated. And bringing a lawsuit, as was done by the governor of Florida, against the CDC, you can cover it, you can talk about the judge's decision, but a key thing in that coverage is, why wasn't the cruise industry party to that lawsuit?
Great. Yeah, I think I'll leave it there. I want to thank you both for joining us during our first session of our health convening. I feel like I have received about 20 different story ideas to pursue going forward, so I appreciate that. And I want to toss to Christopher Worth, who will be hosting our second session on the intersection between Black lives, mental health, and policing in New York City. Christopher Worth, it is all yours, my friend.
Thank you, Sikon. So the idea for this session grew out of a story that I worked on with one of my colleagues last year, Mary McCune. Which in the early days of the pandemic, she had started to follow a number of mental health professionals whose patients were being released from jails to prevent the spread of COVID. And the story was about how they were scrambling to locate their patients. And a large proportion of those patients were, lived in Black and brown communities. And how they were trying to provide them services, get housing, make sure they had all the medications that they need. And since this event is supposed to be about informing our reporters, like what kind of story should we be covering, as a journalist, one of the things that I look for in a story is how can we get the kind of detail or nuance that we draw out so that people, these are things that people don't necessarily know about, but help them understand a complex issue without having to take in too much information all at once. And it's interesting, one of the details that was pulled out of that story is that there is, and this is something that I didn't know about, but there's a distinction between the medications that many people with a mental illness may want to actually take in jail, where they may actually want to be a bit more sedated. It's a very stressful environment, versus the kind of medication that they would want to be on out on the street, where they need to be much more alert. And we did that story out of Cleveland, Ohio, not New York. But at some point, across this country, and this was a while ago, we decided, or maybe we slept walked slept walk, is that a word, into a decision to largely use the police to handle mental health crises. And what I'm hoping that we can talk about are, what are the kinds of stories or ideas that our reporters should be looking into to help us cover a big idea like decarceration, like changing the way that we approach people with mental illness. This is an issue that's come up in the mayoral debates this year. But also, how can we identify those more granular details, like the difference between jail meds and street meds, that really start to help listeners and our readers better understand these complex issues? So I don't think I could pick a better guest to talk about this. Joining me to talk about it is Dr. Mary Bassett. Dr. Bassett grew up in New York. She's the director of the, I'll try to pronounce this name, Francois Xavier Bagnoud, I think, at FXB for short, Center for Health and Human Rights at Harvard University. She's the FXB professor of the practice of health and human rights at the Harvard T.H. Chan School of Public Health. But I think most of us know her as the city's former health commissioner. She served from 2014 to 2018, which was the early days of what is now the outgoing de Blasio administration. Dr. Bassett, welcome.
Thank you. Great to be here.
To the panel. Again, send us your questions. We'll take questions at the end. I think you can do that through the chat function on YouTube. Tweet, if you want to tweet, hashtag is WNYC Health at 2021. So Dr. Bassett, I'm hoping that we can start off with your own experience as health commissioner. Sure. You were there, as I said, for the early days of the de Blasio administration. Could you talk a little bit about how your office began to think about how to change the way the city responded to people with mental health crises, so that it relied less on police, less on incarceration?
Sure. And I guess I should begin with saying some things that I'm not. I'm not a psychiatrist, and I personally have never worked in correctional health services, but at the time I became the health commissioner, the health department, which still by charter is responsible for health services in the city's jails, was directly overseeing the contract with a for-profit provider. And so I saw it from the lens of people incarcerated on Rikers, and I also saw it from the lens of what we were, who entered the criminal legal system. And it was clear that we had too much of the response being led by people who had guns, and that more of the response should be led by people who had knowledge about how to interact with people with serious mental illness. And I guess the thing that got me really thinking about that was the death of a former Marine, Mr. Murdow. He died at the end of my first year as commissioner in an overheated cell in Rikers. He was mentally ill, he was homeless, and he shouldn't have ended up in Rikers, but he did. He was brought there, by the police. He entered the.
This was Jerome Murdow.
That's correct.
I think he was found sleeping in a NYCHA stairway.
That's right. Not really bothering anybody. He just wasn't supposed to be there. Yeah.
And what was it about this case that, sorry, go ahead.
Well, he died, right? He died in an overheated cell on Rikers Island. And he, there should have been another pathway for him. And the other pathway that exists right now is to take him to an emergency department or take him to a homeless shelter. And there are homeless shelters for people with mental illness, but neither of those are very good solutions either. So really, that whole case brought up the kind of huge gap that there is in our ability to care for people, who are mentally ill, and the pathway that's too easy into incarceration, and other pathways being often unacceptable to the individuals. He didn't want to go to the emergency department, and he didn't want to go to a homeless shelter.
So once you had identified the gap, how did the health department start to think about how can we change this system so that we don't have more cases?
Well, a lot of this, I mean, I have to say that I guess this is something that reporters can follow up on. I don't know how these things turned out. I can tell you what the thinking was, that we should have more people responding to calls for an emotionally disturbed person who were social workers or people with expertise in dealing with people with mental illness. In the first instance, unless there was a threat to life, there should not be somebody there who had a gun. And people in the health department began actually responding with police officers to some of these calls. And the other was this idea of a diversion center, which frankly, I Googled a little bit before coming on the program. And it doesn't look like that's gone too well, but the idea was that there should be another place to take somebody to figure out where they should go next, that there should be kind of a respite location where someone could be put safely and securely that wasn't a jail. That was the idea. We need to answer the question, what should the police have done with Mr. Murdow? And then the answer was intended to be these diversion centers. I think, though, that it runs up against, the problem of police culture and the fact that somebody who's trained to prioritize public safety often acquires a culture of demanding compliance. And that can often trigger a whole cascade of events that don't go very well for people who are young, for people who are living with mental illness. And so clearly it seems to me, simply to graft onto the system these additional services won't work unless we have a shift in police culture. There just will never be the numbers of people on the streets of our cities that match those in the police department.
You talk about this, focus on compliance, and I think, I'm a former Londoner, lived in London for a very long time, and I've had the opportunity to talk about a comparison between the way British police approach a situation versus, many British police do not carry firearms, and there are tight firearms legislation in restrictions in the UK, versus the way that US police tend to rush into situations and try to force compliance and, in their view, get a handle on a situation, versus what I'm told is a more predominant British approach to just kind of stand back, assess a situation, and try to de-escalate a situation. Those are two very different approaches. And I wonder, what was the tenor or the tone of your conversations when the health department was trying to interact with an agency like the NYPD, which has a lot of power and has a lot of funding? I think it's there. The NYPD's budget is much bigger than the health department's budget. What were those conversations like? Was it, yeah.
Well, the police commissioner who followed Bratton, Jimmy O'Neill, and I got along well, and I on a personal level. But I think that there is a fundamental difference between a public health approach and a public safety approach. And so we often found that we couldn't agree. So for example, in dealing with the whole epidemic of fatal overdoses, clearly the goal there should be to save lives and not to create a concern about whether or not a drug was legal. Because most of them would not be. And if our goal is to save lives, then that's a very different arrangement than investigating a homicide a fatal overdose as a homicide, and on those kind of things. We couldn't agree. But we did engage in conversation, and I do think that was unusual. I mean, I more than once was, went into that fortress of a building at one police plaza to sit and talk with the top leadership of the police department. And I think that was a start, but they are very different cultures, just as you've said. There is a drive to dominate, to ensure compliance, and to have a cycle that is triggered by a person who's unable to engage in that process in a way that's seen as appropriate by a police officer. So, this is a big challenge, is how to shift the culture of any organization. But it's one that I think as a whole country, we know now that we have to deal with. We still are seeing about 1,000 people die every year related to police violence, many of them people who also have mental health issues. This has remained kind of more or less the same, despite the rising rate of public outrage at how lethal police encounters can be in the United States. We're an outlier compared to other wealthy nations.
You mentioned, and I think many people are aware of this, New York City has a pilot program, or had a pilot program. I'm not actually quite sure where this stands, but where health professionals, or maybe it is DOH/MH personnel, going out on these rides to respond to mental health crises. And other cities, are doing this in different ways. What is as I say, what I like to do is, what is a simple but nuanced detail in these kinds of stories that help to draw out the complexity? One thing that comes to mind is, okay, you have the mental health professional also responding, and maybe they're responding in tandem, or maybe the mental health professional gets there first, I don't know. But what is the chain of command once those people are on the scene, right? How do we pick apart, was that part of the discussion?
Well, that was the question that I asked our team when they said they want to go right along with, in patrol cars in response to these calls. And I asked the question, who's the decider? Who decides when this has, when this situation needs to be under a single command, so to speak? And the single command was always the police department. And so I think that for this truly to work, there has to be a level of response that occurs without a person with a gun. And, just the presence of a person with a gun changes things. And that we hadn't gotten to. I do think that there have been conversations about that, having the EMT, which is a part of the fire department in New York City, respond with social workers, so without a police officer. But it's that sort of thing that we need if we're going to, see the end of these kind of tragic encounters where somebody ends up dead. Yeah. So I don't, that's how you tell the story, is that I think that the story always has to be about saving lives. And I believe that the police department and the health department would both say that that's their shared goal. And the question is, when do the guns get in the way of it?
There's a line that I often hear in this reporting, which is that I think in many cities and counties across the US, it's the jail, it's the prison, it's our criminal justice system that is the largest provider of mental health services in this country. And I think one that says that we've decided not to provide those services outside of a prison or jail setting, but also two, the question of do we lock up these people with mental health needs rather than doing this a different way. And I wonder how much of that figure that we talk about, of the jails and prisons being the largest provider, how much do you think that is being driven by diagnoses that develop before someone is incarcerated or after they're incarcerated? Because jails, Rikers is a miserable place, right? It's a high stress environment.
It's
that is hard
a threat
for a
to
human
health,
being to exist in.
Yes.
Could you talk to me about that distinction?
I'd be happy to, although, the situation has shifted a lot since I left as commissioner. During the time that I was commissioner, the population was sort of ranged between 9 and 11,000. I understand that it's now down to about 5,000 people. And during, after people were kind of, there was accelerated discharge during COVID, it got down below 4,000, which is, a very low number.
Remarkable.
And I would imagine that when that happens, it becomes enriched for people with mental health issues. But before during my time, the proportion of people with mental health diagnosis on quote admission was somewhat higher, but not hugely higher than the population. And many people acquired a mental health diagnosis during their time, and they would be things like, and these were mostly overwhelmingly 80% people who are pretrial, who are incarcerated because they can't pay bail, overwhelmingly Black and Latino, and overwhelmingly young men. And so, they, in the course of their incarceration, start acquiring mental health diagnoses. They have adjustment disorders. They have oppositional defiant behavior. All diagnoses, but ones that it's not too hard to imagine arise from their interaction with an overwhelmingly punitive environment. I don't know if you've ever been to Rikers, but it's noisy. The lights are on 24 hours a day. It's just a really tough place. And in fact, I often heard anecdotally, I don't know if I have the data, that people sought psych medications as a way of sort of, getting sort of phased out so that they could get through their times in a state of sedation. And that, because that was something that worked better for them than being, being alert to their environment all the time. So, the proportion, the numbers that you hear, 40%, don't represent the numbers that were identified on, quote, admission. People develop mental health disorders while incarcerated, including during their time in jail.
So I guess the story is what is this distinction between, are we housing people with mental illness in jails and prisons, right, or are we causing, to what degree, yes, are we causing mental Correct. Illness by housing? Or
labeling behavior pathologizing behavior that is not actually pathological given the conditions. If a guard tells you to do something and you refuse, then that can be on the way to being oppositional. So is this whole question of pathologizing behavior. You've probably heard of this disease diagnosed in the years before the Civil War called drapetomania, which was the disease that caused enslaved people to run away. And this wasn't a bunch of kooks who came up with this idea. These were mainstream Southern physicians who came up with this mental illness that caused enslaved people to run away. So I think there may be some analogies there as well.
Yeah, to what degree are we pathologizing very normal human responses to very bad situations?
Correct.
Yeah. I want to, I don't think we have too much time, and I don't see many questions in my docket here. So I want to turn to something I know you wanted to talk about, which is the way that the city counts police killings. This is something that came up several years ago on a national level, but I think shortly after the police killing of Eric Garner.
Yeah.
Can you talk to me about what did you as health commissioner try to identify? What gap in our knowledge, and what did you find?
Sure. So I refer to this often as my George Floyd moment. But when I was health commissioner, I really made racial equity a centerpiece of my time at the New York City Health Department, which is really an incredible health department. And And it's been hard to see the kind of pressure that that department has been placed under in the past year. But the epidemiology group, the group that does vital registration, came to me saying that what they would like to work on is looking at the number of police-involved deaths in New York City. And they wanted to use a technique that was developed first by the Guardian newspaper, a British newspaper, and also used by the Washington Post. It's been continued by various, mapping violence, fatal encounters, websites. And what it shows is that the number of deaths that have been reported formally through vital registration undercounts nationally by 50% the number of police-involved killings that actually occur. So, and the team in New York City wanted to do the same thing, and they did. And they found that there was indeed over an undercount that was related to that was not quite as large as the national, but still reports of deaths in the media that never made it into the vital registration reports, which the New York City Health Department was responsible for. So they did this whole thing. We talked with the police department about our data. They knew that we were doing this. And what it showed was that particularly there was an undercount of people seeking to evade arrest who died while seeking to evade arrest, and of bystander deaths. But there were undercounts in all categories. And disproportionately, Black men were like four to five times fold more likely to die than white men in New York City. They were more likely to be young. They were more likely to have a mental health diagnosis. So the racial disparity was profound, and Black and Latinx people were less likely to be armed than whites who died in an encounter. So this never saw the light of day, and the data still exist. The most important role for these data, I would say, would be to have a conversation about why New York City, which has lower rates of police-involved killings than other cities, continues to have such a racially disparate risk of death with young Black particularly, but also Latinx men, so much more likely to die as a result of an encounter, whether they die directly, whether they die when they're trying to flee police, or whether they die as bystanders. So, that's the important thing. That's how data can be used to change culture, to get people to say, we all agree on these data. Why do they look like this?
Right. That is an indicator that we should be tracking, whether those data come out every quarter or every year. That's something we should be.
They're not compiled, unfortunately. So the police department is now required to make the data publicly available, but it's like having a stack of paper. They're not compiled by race, ethnicity, age, location. Yeah.
And to the best of your knowledge, the health department is not doing that analysis.
I haven't seen it.
Right. And I'm sorry, what was the driving mechanism that was causing the undercount? Like,
mostly it was, the most undercounted were, there were three categories. So there was a direct encounter that led to death, either tasers, shootings, or it was seeking to evade police, or it was simply being a bystander who dies by accident, and who was uninvolved in the encounter except as a bystander. The largest undercount were in the latter two categories.
And if, in the case of George Floyd, if we look at the initial police press release compared to the actual event, did you find discrepancies? Was the health department able to find discrepancies?
There were, I think, something like 104. The paper is publicly available now. I think you have to dig to find it, but the paper that we wrote up is publicly available, and about a quarter of the deaths were reported only in the media.
Okay. I think I have a couple more minutes. So I want to ask you, the kind of the bigger story arc here when we talk about mental health in the United States is that we used to have these big institutions that were terrible places where we held people, and those terrible conditions were exposed, and we got rid of those institutions. And I think at a certain point, as that process was happening, there was this idea that we would create this network of community health, mental health centers across the United States that would serve this population of people, and might even allow people to live at home and and just live in different settings. And the funding never materialized really for that kind of network of
and the whole
places.
kind of deinstitutionalization led to people being released to the streets, basically, and there were budget cuts. And so, I mean, some of that has been fixed with parity now under the Affordable Care Act for mental health diagnoses. And I mean, this is controversial, and there are many people I admire would probably disagree with me, but the US is now an outlier in terms of having institutional beds. We closed so many of them that there really are no institutional beds in hospitals except in the public sector. That's part of the role that public hospitals now play is care for people with substance use disorders and mental illness. And so the question of the balance between having institutions where people can get, sort of more on track and then perhaps be in the position to be discharged to a community network is a question that I think deserves exploring. But the real problem is always funding, and also the fact that psychiatrists, are undercompensated. I mean, I know that sounds ironic. In general, doctors are overpaid in the United States compared to elsewhere, but there's been a real difficulty with getting enough psychiatrists, able to look after the patients who need them.
All right, Dr. Bassett, I think our time is up.
Well, thank you. It's been fun.
A pleasure to speak with you. Yes,
Always.
Thank you for joining us.
My pleasure.
And now I'm going to throw it back to Sikhan.
Hey everyone, I am back. I am rearranging my headphones so that way they fit. Our third and final session is going to be about a topic that I think keeps me up late at night, and that is long COVID. I think long COVID has the potential to completely overwork our healthcare systems, and we have two great experts here to discuss about how to approach that situation and also how to study it and also how to treat it. So to start off, Dr. Walter Koroshetz is the director of the National Institute of Neurological Disorders and Stroke, NINDS. He joined NINDS in 2007 as the deputy director and has held leadership roles in a number of NIH and NINDS programs, including co-leading the NIH's Brain Initiative, the NIH Blueprint for Neuroscience, and the NIH Post-Acute Sequelae of COVID-19 Initiative. That's another term for long COVID. Before joining NINDS, Dr. Koroshetz served as vice chair of the Neurology Service and director of stroke and neurointensive care services at Massachusetts General Hospital in Boston, and he is also a native of Brooklyn. Dr. Mary Hornig is associate professor of epidemiology at the Columbia University Medical Center. She is a physician scientist in the Department of Epidemiology. She has a long-standing interest in understanding the influence of microbial exposures in the gut-immune-brain axis on neuropsychiatric disorders. As will become apparent in this session, Dr. Hornig is a strong advocate for patient-centered research and for equal access to healthcare. Her body of work includes the first infection-based developmental animal model for autism, demonstration of the role of autoantibodies, a misdirected type of immune response to infections, in a pediatric condition characterized by severe and sudden obsessive compulsive and eating problems and motor dysfunction, which is called PANS or PANDAS. Autoantibodies and distinct immune responses directed against the brain and nervous system have been implicated in myalgic encephalomyelitis, chronic fatigue syndrome, which is a mouthful. It's abbreviated MECFS. And they are now suspected to be a contributor in at least a subset of individuals with long COVID. And I should mention that Mady and I worked in the same lab many moons ago, back when I was a baby science writer. Mady, I want to start there. I want to start with you. You experienced long COVID. Do you want to briefly discuss what happened, your symptoms, how long they lasted, and how you sort of approached thinking about your symptoms from the perspective of a physician scientist who has studied these syndromes in the past?
Well, thanks, Sikan. It's really great to be here. And I would correct that to experiencing, so not past tense quite yet, about 15 months in. And it has been a sort of a unique opportunity in a way to, and a privilege in a way, to be able to see this from the inside out. I don't consider myself to have been as severely affected as some individuals, but the manifestations across so many different body parts, right? So many different organ systems, the onset of disease, so it was very perplexing and was not really apparent, except in retrospect, that I had likely been infected, along with my 9 doctors that I've had over the past, in 2020, was $62,000 of medical billings and treatments. Wow. And been able to piece together that most likely there were features that were not usually at the type that would herald an infection. So the fever that I had was already almost a month after the other symptoms began. And some of that included COVID toes, which was only being described at that time in little kids. And I was like, what? But I couldn't get my shoes on. I had to go to the pharmacy to get medication for my son, and my feet were my toes were just 1 foot, very swollen. I thought, fine, I'm just banging around the house without shoes on. I scraped my toes, so forth. But when you start to sort of think about the trajectory, there are many things that are not of concern enough for me to go to a physician in and of themselves, but they tell us something about the systemic effects and other aspects that may be really helpful, give us clues. I'm what we call an N of 1. If you do a study and you're just doing it on one, subject, you're not really going to have a whole lot of information that will be necessarily generalizable or even reliable, but one has to start somewhere. And I think there are ways to begin to look at those things and to ask questions. And through my work in epidemiologic approaches, also try to think about who are we bringing in to study, right? So I've just started as one of the patient representatives associated with one of the Columbia cohort on PASC, the cohort of cohorts, collaborative cohort of cohorts, as C4R, and working in this recover cohort at NIH to try to figure out who do you look at, how often, in what ways, so that we can really understand the mechanisms here. So this is certainly a disorder that we worried about from the very beginning. I was, at the time that I was first becoming sick, I was writing about the potential for what does this disorder portend for MECFS, and that's the sort of the abbreviation that prefer, or ME, because we know that viruses and other infections can be at the start of the illness. We don't really even know how they relate exactly to this very longer term, sort of long COVID, if you will, and to understand what's happening there. So maybe we'll be give us an opportunity because of the numbers, the huge numbers of individuals, to not have a sort of a medical gaslighting experience. I had that too, right? So, when one of my docs said, oh, I see that you're on really high dose aspirin. Has anybody ever said that, long term, has anybody ever said you should come off of that? And I said, yeah. And in fact, I'm on ulcer medications to prevent the side effects of that can come along with aspirin. However, it is also, in addition to being anti-inflammatory, it also can have some anticoagulant effects. So would I have had, instead of the little tiny clots, the microthrombi of COVID toes, could I have had a great big tree trunk, venous thrombosis that could have, been highly disabling and perhaps even, permanently disabling or lethal. So
yeah. I think that's a great table setting for everything that we're going to discuss. But Walter, first I want to approach you with a similar question. How are you approaching the symptoms around long COVID and what might be going on in the body? And also, you're muted, I should point out.
Right. So I think, as Mady hinted, we're really dealing with a mystery right now, but it's a mystery with these kind of confines that hopefully will get us answers. So she mentioned there's a long story about people who have had what seems like an infectious illness. They just have persistent symptoms. They have waxing and waning symptoms. And, after 6 months, it's called ME/CFS. And we've never been able to try and figure that out. We've never been able to figure it out because we didn't know what the infection was. Oftentimes, it was years after the onset that anybody came to attention. So trying to piece it together to find out what is the underlying problem in ME/CFS has been very, very difficult. And people, really good people like Mady and the other people at Columbia working on it for a long time. And so with COVID-19, unfortunately, we are seeing a cluster of symptoms in people whose lung infections appears to be resolved. And those symptom clusters overlap very considerably, sometimes identical with what you see in people with ME/CFS. And so those are, for people who haven't been familiar with them, there's probably a list of 70 different symptoms, and most people will have a cluster of multiple. I think the average might be like 13. And the most common one is fatigue. So talking about chronic fatigue syndrome, this is definitely chronic fatigue. And that in some reports is as high as, if it's asked, it's as high as high 90% range. And along with fatigue comes trouble with cognition, and that's trouble. And people have done some studies with formal neuropsychological testing, found difficulty with some forms of memory, with executive function, and with we call executive function, where you're trying to make changes in your thinking, going from one thing to another quickly. So slow thinking. I think the word that people use on the street is brain fog. Of course, that's not a neurological term. There is no fog in the brain. Just seems that way. But there are these, definitely neurological difficulties that people are having with cognition. And I think that is probably very disturbing to folks. It may prevent some people from working. There are a lot of people who are working, but it's a lot more difficult to get their job done than when it was in the past due to this. And then there are a number of other things. In the neurological space, there's a lot of pain that people have been describing. It can be chest pain after the viral pneumonia. And in some of those people, there's shortness of breath as well. And some of those people may have injury to the lung that's still resolving over time. But I think from talking to the docs taking care of folks that in significant numbers, they don't find anything wrong on the pulmonary function test. So it's still a mystery as to why people are having the shortness of breath and the dyspnea. And that needs to be investigated. There's abdominal pain, there's diarrhea. People are complaining of what's called postural orthostatic tachycardia, where there's a sense that your heart is racing, oftentimes in relationship to standing up, feeling sometimes faint with that. And that is also very common in ME/CFS, I would say. It can occur by itself, but oftentimes it's concomitant with the sense of fatigue. And the one signature feature of ME/CFS that we need to look into more in post-COVID, and I haven't seen good studies, although I have seen reports, is what's called post-exertional malaise. And that's best explained by people who have this waxing and waning fatigue. And on a good day, they feel, well, maybe I'm doing okay today and I'm going to go out shopping. Nothing strenuous, but that is enough to kind of get them really sick for the next 2 days. So they'll come back and then the next day they feel terrible. They can't get out of bed, maybe nauseous, incredible fatigue. So that is another one of the signatures of ME/CFS that we have to watch out for. Mm-hmm. Now, we know that there's a lot of tissue injury that occurs in COVID-19. So, there's a pneumonia, there's potential for scarring, potential for changes in the way oxygen diffuses into your lungs. There can be kidney disorder, liver disorder. But in fact, we don't actually know that the virus is gone. So people, their PCR is negative on their secretions, but we don't know if the virus could be hiding somewhere. In Ebola, we know that people can actually have virus for a long period of time. It may not be competent virus. It could be RNA from the virus that got into our system, and it's still making some viral proteins, but that would stimulate the immune system, and so you would really not be over it. Your immune system would still be, seeing that. And then Mady's expertise in autoantibodies is a huge immune response that comes with COVID-19, and certainly there have been described autoantibodies developing. In some studies, they've seen autoantibodies in the spinal fluid against some brain proteins. There's questions about whether reactivation of Epstein-Barr virus could be at play here. That's what causes infectious mononucleosis. And if you think about the symptoms that people have after a COVID infection, we knew from the summer, last summer, that when the CDC did their study, they showed that in non-hospitalized patients, 35% were not back to normal at 3 weeks. And their data said that if this was influenza, it would be 90%, should be better. And that's the non-hospitalized patient. That's, so that's something that you would see in mononucleosis for sure, right, where people are, kids can miss a semester, maybe even a whole year of school with the fatigue that comes after mono. So we have, a lot of mysteries. What we like to do is to get some evidence of what is the driving factor in the short term so that we can test interventions. Because we're all afraid that the longer this goes on, the harder it's going to be to help people get better. So right, we need a really big push to understand it, and then we need a little luck so we find something that would lead to intervention that helps people. So that's the goal, the major goal of our research. We're happy to talk more about.
Perfect. And then I'm going to come back to how the NIH is approaching the studies on sort of the umbrella level, sort of the 10,000 foot level. But Mady, first, how do we kind of break apart those driving factors in a condition like post-COVID? Given your work on ME/CFS, chronic fatigue syndrome, how do individual labs even go about breaking the syndrome into pieces so that way they can study them? Is it about grouping patients, like, oh, well, here are all the patients with fatigue over here are all the patients with headaches over here? It's about animal models. Like, how do we go about actually studying that?
That's a really excellent question. I really thank Dr. Karsetz for such a really great and sort of comprehensive summary of the types of ways and factors that people are thinking about. One of the and as Sikan, you're sort of speaking to the question of phenotyping in a way. So are we, and that can be clinical phenotyping, or it could be use of biomarkers to subset individuals and then look to see how they may differ clinically, or how their course of illness may differ. So I think that one of the really key factors now, as we and others are trying to think about what should we capture now, right? Because sometimes you may forget things over time. If you're somebody who's affected by by this disease, you may not think to report it. And also because there have been many barriers for individuals speaking to their physicians and saying, I have this issue. And if it's not something that is where the patient is seeking treatment for that, the physicians may say, well, why are you telling me about that? We're not going to focus on that. So physicians are also quite frustrated. They open their toolkits and most of them come up empty as well. So one of the things that we think about in terms of, to the extent that that we are going to see cases of ME/CFS that are triggered by SARS-CoV-2 infection. And I've been convinced that there are some cases that are being identified. Question is really, have we really done the right studies yet? I don't think we have at a population level to know whether this is something that may, because there's a sort of a natural incidence of ME/CFS over time. We don't really necessarily know. And even in those cases where we have Epstein-Barr virus, for example, in the past, that has been tracked longitudinally to see how many people will develop and meet criteria for a diagnosis of ME/CFS, it's about 10% and so forth. We still don't know how Epstein-Barr virus infection actually results in the condition, right? Are there pre-existing risk factors? Are there things that didn't happen? Whether, at the time one was initially ill, did you not rest enough, right? So that's been a very big issue here, because there are some groups that are, talking about the need to kind of, you're just getting deconditioned or whatever. So some of the really key questions for me when thinking about the brain aspects or nervous system aspects of this disorder is relating to how do you end up with the manifestations in the nervous system, and what is causing that? Is there evidence of virus that it perhaps is cryptic in certain areas? We do have some evidence of that. In fact, for some of the respiratory symptoms, there's a intriguing small study, but where they found that it's not the pulmonary damage itself, but it's rather that there is the driving from the respiratory centers in the brainstem and the vagal nerve, right? So what part of this autonomic nervous system that's been described, that there's maybe infection in small numbers of cells, but in key regions that may be contributing to dysfunction in this pulmonary brain respiratory center axis. We need to be thinking about those sorts of things more. We need to know, of course, we don't want to, we're not eager to give up our brains for, for assessments, too early. So, are there ways that we can identify some of this, some proxy for this in certain things that may actually end up getting to the blood from the brain. So there are these little, sort of storage vehicles that called extracellular vesicles that can be derived from the brain and or from the barrier that goes between the blood and the brain, and that these can then enter into the blood. So you can study them there. And they have what you call cargo, like little lipid, wrapped ships that have RNA and so forth. Could those even be sites where viral RNA is hanging out? Is it really infection and replicating virus that is persistent? Or is it possible that at least some component is because we're either have all the factors that allow a messenger RNA molecule to persist are enhanced, right? Or the ones that cause destruction are decreased, right? So and then how would one imagine that the presence of that viral RNA may participate in the symptoms? We also know immune system can be altered. There are messengers, the immune molecules, cytokines, chemokines, those talk to the brain. We also know that there could be blood flow changes. These are things that are now being described more and more through some studies that are looking at the contribution to postural orthostatic tachycardia syndrome, right? In addition to autoantibodies, or maybe in association with autoantibodies that target that part, that adrenergic or the autonomic nervous system, that may have a change in blood flow. I also really advocate for us not only going from, what we're seeing in long COVID, but actually trying to understand what is in ME/CFS that we might look for differently in long COVID. And endothelial cells have been described in long COVID, but they also have been described in ME/CFS. Would we have, if we had really started with what we know about ME/CFS pathology, maybe there would be things that would allow us to look smarter and faster and differently and more to an eye towards the future, what we can collect now and then go back and and study over time. And last point is just not to forget about studying markers of resilience. As much as we need to know vulnerability and what makes us ill, we need to know what makes us better. So that's a really strong call for not excluding from all of our studies individuals with long COVID who get better. Mm-hmm. First of all, they may continue to be at risk, which I hate to think, but just personally, but also perhaps there's this idea that maybe certain neurodegenerative or other metabolic disorders that are just incipient and waiting to happen when COVID-19 hits, maybe those get precipitated, and maybe that adds to some of the dysfunction. Anyway.
It's fascinating. I mean, to think that parts of the body that might be getting infected in the lungs or sort of have connections to the lungs, like the vagal nerve, maybe they're sort of working as a conduit for these larger hazards that we're sort of seeing around long COVID is interesting. And then I love the idea that the function of parts of our cardiovascular system, so like the blood brain barrier and other cardiovascular markers might serve as a way to sort of read what's going on with long COVID. That's pretty fascinating. I call dibs on that story. No, just kidding. Yeah. Speaking of the audience, we have a few questions that are coming in, and I think that one of them can sort of speak to the NIH's plans for studying long COVID. So we have a question about how does the likelihood of COVID becoming endemic impact your view on the steps we need to be taking now, I think, to both study and treat COVID? And what is the common thread, or is there one, among the people struggling with long COVID? And how do you find people to participate in the studies? So I don't know if Walter, if you wanna hop on some of those questions.
Yeah, so as I mentioned before, the thread is really these clusters of symptoms that are very common in people who have had COVID and just not getting better. And as I mentioned, I probably missed a whole bunch of them, but the people generally have a host of these symptoms, so that's the common thread. Now, the studies that we're planning, one of them is really time sensitive, given the fact that the good news is our rates of acute infection are going down. What we'd like to do is to study people who are infected and then follow them over time to see how the different body systems improve over time or don't improve over time. Because what we really need is a comparative group where a signal is going to jump out in the people who have the persistent symptom. So the great natural experiment is people with COVID look at their immune system, look at their cardiac system, look at the pulmonary system, and just see how it recovers and what's different in those people who don't recover versus those who do. So the resilience thing that Mady hit. The second, and that group it's time sensitive because now is the time to do that. If we wait too long, in this country, hopefully we're not going to be able to do that study anymore. The next study is really looking at people who already have persistent symptoms out months and compare them to people who had COVID and are now better. So now you have two groups, but you missed the period of time of the recovery period. You're left with the more static situation. And to have those groups studied, again, have their neurologic function studied, their cardiac, respiratory, pulmonary, GI system studied, to see immune system, to see what distinguishes the folks who are still having trouble from those who recovered. Those are the two main cohorts that we're looking for. And we're looking for, 10,000 patients, because Congress really last summer, Congress got very worried, appropriately, about this condition, and then appropriated, I think it was in the early winter, $1.15 billion for this kind of research. We have the opportunity to do this in a big way now. The other aspect I wanted to mention, and Mady hinted at this, is that, in fact, we do have an autopsy component to the studies, because there are certain things that you can't guess at from looking at the blood. You really need to look at the tissue. And so if anyone who's had these symptoms of post-acute COVID and they happen to die, in that period, probably not going to die from post-acute COVID, other reasons that they may have died, but we will try and bring those tissues in for intense study, looking for things like presence of the virus, persistent injury, persistent immune triggers inside the body, something that unfortunately in ME/CFS we've never been able to do. So that's another component. And then the last component is kind of an electronic health record study looking at millions of people. And there have been some of these already. So the Veterans Administration published something, a couple of big healthcare systems published, and what they've been able to look at is, new diagnoses that have come to people who had COVID, and they can compare them to the incidence of those diagnoses in people who never had COVID. So you can see things that are COVID related. And many of them relate to the symptoms that we just talked about. But in addition, given the fact that 33 million people have been infected, we do need to set up a system where we're looking for things like Mady mentioned, in the future. So having had COVID in 5 or 10 years, is that going to affect your chance of developing dementia? Or since the virus can attach to these endothelial cells, is that going to affect your chance of developing atherosclerosis, a heart attack, strokes? And you can, there's a whole host of things you could worry about. Now, of course, we're thinking about the future now. There is no, I don't want to get people overly concerned that there's something, portending out there, but we need to know, we need to be able to follow, because this was such a hit to the healthcare of the US that we need to have our eyes open and be ready to look and see, what are the long-term effects. And that's best done through these kind of long-term electronic health record studies that can now look at millions of people. So those are the 4 components: the electronic health record, the autopsy study, and the 2 types of cohorts. Those are the acute infected and follow how they get better, and those who are now out, months and still have symptoms, compared to people who have improved and back to baseline.
Perfect. And we have a bunch of questions coming in, and I'm going to remind folks if they want to send more questions in using the chat function. We've talked a little bit about ME/CFS, chronic fatigue syndrome. We have a question of, to what extent is long COVID just the newest iteration of ME/CFS, versus, what aspects are unique to SARS-CoV-2? Is this just a generalizable thing to some infections? And is it important clinically to make that distinction between ME/CFS and SARS-CoV-2, or post-COVID? Maybe if you want to start.
Yeah, I'd love to jump in on that. I think that it gets down to a fundamental question that we struggle with as in the field of ME/CFS is to is it a homogeneous disease with some heterogeneous manifestations? So is there a unique cause? And really, at what level do you see that cause? Is the trigger really, that's not necessarily the most proximal cause to the event, perhaps, or the series of events that will manifest as, the disease state. And we do, we know from some of our prior work, we saw changes in the immune system depending on the duration of illness. So we saw that in the immune system, there were some findings that were suggestive early on of a more inflammatory type of response, with a pattern after about 3 years of illness with ME/CFS that suggested a viral exhaustion that affecting the immune cells. So, and there are ways that we can examine something, that you can look for the memory of these cells for different types of viruses. There are some individuals who think that, herpes viruses, or that perhaps the reactivation of herpes viruses like Epstein-Barr virus, which is the cause of, infectious mononucleosis, that may be one of the reasons why individuals with SARS-CoV-2 infection end up with an ME/CFS type pattern. That it, so we don't really have full consensus on this issue. We do have the opportunity now. I hate to call it an opportunity, but it is. I mean, we have a chance to have so many individuals who are not ignored, right? A year ago, docs were still ignoring. Docs were still saying, I don't know, this test is negative, so it must be something else. It must be you're having tachycardia, just sitting there, 145, 150. You're having this because you have deep-seated issues. Maybe you could pursue therapy. And so it is we have this chance now because we have, I've been able to bring my docs around to say even before my tests were positive, right? It took me a year to have a T cell reactivity test that told me that my T cells were screaming that, yes, we've seen this virus before, all different parts of it, or, we remember that. But so there are individuals who are in that, state. And I think I helped bring some of my docs around. We need to bring a lot more docs around to the viewpoint that there was no better explanation for all of these symptoms to be coming up, which were not all sensory. There were some, thankfully, in a way, leg swelling from, from toes to thigh, just one leg swelling. They thought I had a clot, right? So there, that there's, so that as long, I think that's a benefit, but there's still a lot of naysaying docs, and so people. And patients are either reticent or don't know who to go to for these things. I think we must think very carefully about diagnosing individuals, even post-vaccination, if they have mild disease, a mild reinfection. We need to be able to get to these people because we need to understand what this is. Pandemic stress is also a real thing. Right. And we're all affected by that. That certainly exacerbates many things, but we need to focus on diagnostic tests that tell us about not just the risk for, but, to say that, we think that there is a consequence in biomarkers that maybe it's just a proxy for something else, but it's some type of biomarker that can be tied to infection at some point in the past, and that can be also serve as a proxy biomarker for the long COVID, right? So for the for the ME/CFS manifestations, I think it will improve our ability to not only have a cohort of docs who, I didn't see this in medical school, right? I didn't learn about this in medical school. We'll have a cohort of docs who perhaps will be educated to these manifestations and maybe have something in their toolkit maybe a year from now where they can begin to look at this. But first thing, you have to identify it. And we don't want too much time to go by, right? Because then you may miss all of the important action. So this investment, of the 1.15 billion plus some for also, I think specifically for ME/CFS and other chronic diseases, I think is really critical so that we don't forget to look intensely now, don't forget to collect what we need to do that we don't even know yet necessarily what to do with. But if you miss that opportunity to get the blood sample, you can't go back to it. Right? And you have to ask people questions that are going to be meaningful in terms of understanding what happened when. I may not have, I didn't remember that I had myopathy. I had one muscle that was infected before at the very start of this. I thought I must have hit myself. I could not bend to get out of bed. I had to roll out of bed. It was so terribly painful. That's the only pain I've had, fortunately, is I have neuropathy. This is the great wonders of neuropathy is, autoimmune neuropathy, so that, that's pre-existing. People would potentially forget these things. So we do need to gather the information rapidly, be smart about the questions that we might, that we are asking, but also keep looking at that and see where the patterns arise and, bring everybody to the table.
And yeah, and Walter, I want to get your opinion on that too. And we have another question that came in that was for you that also, I think, factors into that question. How can we integrate ME/CFS, chronic fatigue syndrome, knowledge about it into the Recover initiative to help accelerate our understanding of long COVID?
Well, I think Mary's the expert on this one. So I may be different, but I would defer to her. But what I would say is that, ME/CFS has been incredibly difficult to understand. And we don't know what the drivers are. We don't have treatments that work. Maybe there are some things that work in some people, but nothing's been proven as definitively beneficial. And we have people who are, bedbound for decades. So in my thoughts, my hope is that this natural experiment, which is a horrible thing that happened with COVID, that this is our chance to figure out what causes the ME/CFS syndrome in COVID. And if we're lucky, the drivers will be identical. And we'll find out from the COVID patients, those COVID patients, something that then applies. It's kind of like an epiphany. Well, that's the problem. You know, it's that antibody or it's that T cell group that is distinguishing the post-acute COVIDs from the people who've recovered. And then we go in and see the same thing in ME/CFS. So my sense is that studying post-acute COVID is our best chance at understanding ME/CFS. And on the flip side of this, and I'm not a pessimist, I have to say it, that I would think if we don't figure this out for COVID, I don't know how we're going to figure it out for other forms of ME/CFS. Because this is, you know, here you have thousands of people, you know exactly when they got infected, you know exactly what the timing is, and you know what the virus was, and you're going to know a lot about the viral response and immune response and how people get better. So this is our chance, I think, to understand ME/CFS. So that's how I see it. Now, maybe they see it differently. Let's see what she says.
No, I mean, I certainly agree with the idea. You know, and I'm not giving away our shot, right? This is it. You know, that is really, really critical. Even if there were 0 cases of what we typically think of as ME/CFS that were really similar, you know, to this, because I think there are aspects of ME/CFS of SARS-CoV-2 infection, you know, of COVID-19 that are sort of a special flavor, you know, if you consider, I don't know, I can't call this ice cream, you know, with it, but there's certainly, you know, the different, there's different versions in the, I think the coagulation system impact of SARS-CoV-2 infection is extraordinary. And you know, and may add some unique aspects above and beyond. But I think that when we start to look at where the overlap is and try to understand the trajectory of, you know, from the beginning and from the onset of illness and getting people with ME/CFS as early as possible, right? So, you know, maybe we want to have a pre-diagnosis for individuals with ME/CFS, you know, before the 6-month mark, you know, because it is smart for people's long-term health, because it's smart for potentially preventing long-term disability. So these are, you know, important aspects. And I think that we will have, I think, a better way to make sense of this and actually use the evidence to help us test hypotheses, you know, in a way, if we're really looking early. So individuals who develop ME/CFS who turn out not to be, you know, positive for SARS-CoV-2 by any test, you know, even a T cell reactivity test, you know, we need, I think, to, you know, to really step up our game and how we are doing the process of diagnosis, right? And maybe we should have a, you know, an interim type of diagnosis, a provisional diagnosis of ME/CFS, because there are things that people, you know, perhaps, you know, should not be doing, right? And perhaps rest, if you have had an infection as at the onset of your illness, perhaps rest and other, you know, supplements, you know, is there an oxidative stress component that drives some of the immune disturbance and the autoantibody production in, you know, in ME/CFS in general? And, you know, should we be implementing some of those things at an early phase, and then not come, you know, but use enough of what we learned with long COVID to not come back to those people who had the provisional diagnosis of ME/CFS and see, you know, and say, hey, see, it was all in your head, you know, right? So we have to do it carefully so that we really learn for the future and we aren't dismissive of the enormous, travesty, really, of the absence of healthcare options in most communities across the U.S. Docs don't know what this disorder is. We have to fix that.
Yeah, I agree.
And that is a great setup for my final question, which is the question that sort of keeps me up at night about long COVID. To set up that final question, Walter, I was wondering if you could run through how common long COVID is. What do we know about the prevalence right now?
Well, I think that we don't really have the accurate numbers we need. What I would throw out is that the studies that were coming out of Europe, looking at people who were hospitalized with COVID, were reporting that about 50% were still not back to normal at 3 months. And then the CDC study I mentioned showed the people in the US who were not hospitalized, 35% were not better at 3 weeks. And then you have the VA study, which again shows that people who are in intensive care units have a lot of problems that come up over the next 6 months. People that were in the hospital, non-intensive care unit, have fewer, but still lots of significant problems that come up. And that's that's probably in the 10 to 20% range. And then people who were never hospitalized, it's in the single digits. It looks like it's in the single digits. Now, that's percentage-wise. Then if you think about all the people who got infected with COVID, then most of the people were never in the hospital. So in post-COVID, the largest group of people are the people who were not hospitalized. And I must say that we knew right from the beginning that if you have acute respiratory distress syndrome, COVID, no COVID, that's a very long recovery period. Data is that at a year, 75% of people are not back to work. That's a very severe stress. And the symptoms are very similar. Fatigue is a big one, exercise intolerance, pain. So the big surprise, I think, with COVID is the fact that the clinics that have developed to see people coming out of intensive care unit are now completely full of people who are never even in the hospital. But I think we'll get better numbers as we get some of these reports coming in of the big healthcare system or a prospective study.
And I asked that question because we have, I think it's well over 160 million people who have recovered worldwide from COVID. We have close to, I think, 1 million people who have recovered from COVID, or sorry, I should say have survived the acute infection in New York City. Even if the long COVID rate,
it's a big number. This is a big number.
If the long COVID rate is 1%, I mean that's a lot of people.
That's correct.
Mady, I think you were saying the costs that you experienced with long COVID were in the tens of thousands. I mean, the question that keeps me up at night is how our healthcare system is notoriously bad at I think handling, treating, paying for chronic disease, whether we're talking about diabetes or we're talking about Alzheimer's disease. So, I guess from each of you, what are the one or two things that you would want to address immediately to provide support for long COVID patients going forward in any realm, whether it's healthcare, whether it's rehab, what are the priorities for you? And I'm giving you an unlimited amount of money to do it. So what would you pick?
Yeah. Well, I'll take a fast stab at that. I think that my first step would be to try to get assessment of illness out to everyone. I've been working with a group that was actually quite influential in some of that fundraising and advocacy, on the Hill. So Solve ME, they have developed a mobile symptom tracker for ME. CFS, and then they, put a COVID-19 specific type of, tracker on top of that. These sorts of platforms can be accessible in lots of places, maybe not everywhere, but people can follow their symptoms. They can actually see what their symptoms look like over time individually, as well as compared to the population as a whole, different age groups, and so forth, but also to get at what we would call a research grade diagnosis. One of the side benefits in a way of the pandemic was that we are able, at least temporarily, to cross state lines as physicians, right? So you can do telehealth, telemedicine visits. And so we are hoping that there will be an opportunity to utilize, the ME clinician expert teams. There's a U.S. Working group that is that's some of our collaborators over a long period of time, and they and others, can see patients in a confirmatory virtual visit, and then patients can take that to their local docs. Furthermore, we can really be finding ways, perhaps through agencies, not usually with NIH, but perhaps services outcome research. We can look at the possibility of doing teleconsultation, so that physicians can get reimbursed for consulting to groups of docs who present their cases of patients, right? And they learn from each other, and they also are local to one another. So perhaps, that can help also in terms of understanding the, socioeconomic, cultural, et cetera, aspects and what's available in that particular area. So there are ways in which we can utilize some of the side benefits of the pandemic, and, okay, Zoom world maybe is not always so great, but there are some benefits. And in terms of health equity and bringing access, we've been studying some of the barriers to bringing, Black and Brown peoples, indigenous populations to the table. They've had high risk for COVID-19. What is the risk for long COVID and for ME/CFS? In ME/CFS, we almost don't know. In fact, if you went to most studies and you looked for individuals who, were of, Black, indigenous, people of color, you would almost perhaps conclude that they were resilient, because, where are they? There's no one there. We're not recruiting. We're not yet. So we must address that now. We must know rapidly what the answers are, and we must be able to address, when people have pain, if they need some type of management for that pain that involves, for a time, some type of, opiate, opiatergic agent. We don't want to lose the opportunity to to get them the access that they need, but there can be so much stigmatizing types of things that go on there. We really need to address those. So I would really invest in that aspect and increase the research, and along with that, and I think there will be great benefits along with that. And we can actually utilize docs in the field to help us give their experience in managing individuals, but we have to give them some toolkits first, right? Because who wants to diagnose something you don't know what to do with, right? How are you going to help somebody, right? So that's and we need docs also to work together. It's not in most docs playbooks, they have sort of all the little specialties, but we really do need to play better in the sandbox.
Mm-hmm. Perfect. So yeah, tools for patients to understand what's going on with them, and also training doctors who are seeing these patients and might not be, I guess, neurological experts on how they can spot the disease. Walter, what's your answer? You have one moonshot to support patients. What do you do?
Well, so I'm from the NIH, so our agenda is a little bit different. So what we'd like to do is fill the toolkit for doctors so that they have treatments that work for patients. So that's clearly our first goal. But if I take off my NIH hat and talk about, what it's like to be a clinician, I think that, and certainly from my experience with ME/CFS, there's a real shortage of people who have the kind of courage to take care of people when they don't have a pill that you can give them. But that's what medicine is, that's what medicine's been like forever. It's helping people get through their illness so they don't have to get through it alone. And, to try and work, as best you can to kind of reduce their suffering. And there's lots of things that you can do in this condition. You can treat the pain, Mady said. You can treat the sleep disorder properly. There may be cardiopulmonary rehab that can improve their exercise tolerance, or we even heard of breathing therapy to improve the sense of dyspnea. And also, the truth of the matter is, this has just been a tremendous stress on medical system, but individuals, people with post-COVID, a lot of them had COVID and they were worrying if they were going to live or die. Some of their family members died. And now they're not getting better from it. So the stress is just enormous. And so that's not to be ignored either. So post-traumatic stress disorder, anxiety disorders, and depression are going to happen. I mean, it's not the saying it's due to depression. Depression is due to this problem. So it takes real doctors, I think. And the good news now is that, with ME/CFS, it never kind of rose to the point that, hospital systems really took it upon themselves to say, oh yeah, we're gonna put the center together to treat this. There are a few, but they're like, you could count them on one hand. But here with the numbers of people who are going to be suffering, you can't ignore them. So the hospital systems, they need to react. And you could think of, this is what we need to do to have a care system for people with post-acute COVID. You could write it down, and you had the funds, you could put it together tomorrow. And hopefully you would have better success rates as the more information comes in. But that's what medicine is about. It's about taking care of people, trying to reduce the suffering as much as you can. A lot of diseases you can't cure, for sure.
And I think that's a good place to leave it. And just to close, I think the through line between all of the three sessions that we had today for this convening is that the pandemic is not over, and in some ways it is completely reworked and continues to rework our approach to healthcare. In the healthcare system, and it will for years to come. I want to thank Walter and Mady for joining us for this third session.
Oh, Sikan, it's great to see you again too.
Yeah, to see you.
Great to see you, Mady.
Yes, great. Yes, really great. Thank you. It's really.
I want to thank my co-moderator Christopher Worth and Mary for their excellent session on policing mental health and COVID, which everybody should go back and check out in case you missed it. And I also want to thank Celine Gounder and Jeffrey for the first session that we had today on the future of mRNA vaccines. Yeah, and I want to thank everybody in the audience for joining us for the WNYC Health Convening 2021. I appreciate your time. All right, go forth. write stories,
Right.
except for the stories
Very
that I
much.
want to cover. No, just kidding. Take care, everybody.
Right. All right. Bye now.
Bye, thank you. Bye.